Our next speaker really deserves no introduction because everybody knows him. We were at speaker's dinner last night, and Dr. Esquivel arrived, and I was looking at him across the table, and all I can think of the word is global. He's a global leader in the treatment of this disease. And in terms of our journey, he is really, when we got our program started here, he was a big part of our journey. Hope you guys can hear me. I asked him to come to help us get things started, to observe a case or two, and to render his opinion what we could do better. And he was not shy about rendering his opinion. And he has been instrumental to the success of our program and the success of the treatment of patients with this problem. He is a guy from New York. He was trained by Dr. Sugarbaker a few years ago, and he's a fabulous speaker. I have to have him every year. I marvel what he says in conferences. He's got the greatest quotes. I'm sure he's going to have a couple today, and I don't want to hold him up. Are we ready, Joe?
Almost.
All right. No pressure. We're going to try to stay on time here. Dr. Jesus Esquivel.
This is being recorded. Some of you may not know, but I was told that there's a lot of worldwide interest on this symposium. So it's being recorded and it's going to be transmitted, uploaded on the internet, and the people from Australia wanted to participate. But anyway, so there's a mistake on the brochure. You know, it says that I have 30 minutes. No, it's 2 hours. So bear with me. And it is an honor, literally. It's an honor and a pleasure to be here. I want to thank not just the organizing committee, but Dr. Baum, especially. You know, how do you follow his presentation? You know, you saw that energy, the commitment, and it takes a very smart person to surround themselves with even the smarter people to make this happen. So both, thank you very much and congratulations. All right, so I'm going to talk over the next 30 minutes about the evolution. It's kind of like the journey, you know, in the treatment of mucinous appendiceal cancer. And let's see, okay, I do have some disclosures, but they're not relevant for this presentation. We're going to talk about these highlights of 3 different eras. Where are we heading, barriers to getting there, and how we're making progress. And I think that, you know, the quote would be progress, not perfection. You know, I think that's where we are. Today, better than yesterday, but still a lot to conquer. This is where I am right now. I'm in Frederick. For anyone that doesn't know, that's where Francis Scott Key wrote the national anthem, and you can visit there. And I'm at Frederick Memorial Hospital, which is one of the MD Anderson Network certified members. The 3 different eras are going to be from 1842. And I know that Dr. Siegelman is going to correct me when I say when was the first case described, but it is the first case of pseudomyxoma peritonei syndrome, Dr. Siegelman. Okay, so we're going to talk, so the first case was described in 1842, so that's the first era that goes from 1842 to 1978. Then Wirth coined the term of pseudomyxoma peritonei, describing it with what is very common, you know, think that this is of ovarian nature. And in 1901, Frankel described the first case associated as a cyst of the appendix. So I'm talking about pseudomyxoma peritonei syndrome, not just the term pseudomyxoma. So this is what we used to see, you know. We don't see these patients here, and I apologize. I think there were some kids in the audience, and maybe some pictures that may be a little inappropriate, but it's the reality. We used to have a lot of patients like this in the United States, but I go to Mexico, which is where I'm from, and that's where we still see patients like this. You know, that's the ultimate jelly belly. So what happened during that time? The standard treatment was to take a patient like the one that I just showed, open them up, take out the mucin, close them back up, and do it again when it came back. And the people at the sorry. I gotta get my glasses for everything here. Yeah, from the Mayo Clinic. So they reported 56 patients, and the median survival at that time was 26 months, just with this open, evacuate, close, and do it again. So not, a lot of improvement that needed to happen to better serve our patients. The second era starts with the first HIPEC. The first HIPEC was done in Louisville, Kentucky, in a 47-year-old man from Japan. Dr. Spratt had made a machine for HIPEC delivery in dogs. And then this patient from Japan heard about it and said, I think this is what I need. And in the same year, Dr. Spratt published in the Journal of Cancer Research the delivery of HIPEC in dogs and then the first HIPEC in a human. It's fascinating. And then every time we have a meeting, we always say, what happened to Dr. Spratt? Nobody seems to know if he did another HIPEC or not, but I think that was, Paul, you can corroborate, right? So an N of 1. And then part of that second era is Dr. Sugarbaker. He published the Sentinel paper. How do you turn this operation from just, open the patient, evacuate the mucin, into a systematic approach to the treatment of patients with a massive amounts of disease? So that was the journal, Annals of Surgery, 1995 publication by Dr. Sugarbaker on peritonectomy procedures, and that changed the lives of PNP patients forever. So thank you, Dr. Sugarbaker. This is what happens. You see a patient with a massive amount of disease. The key thing here is you can see the small bowel. There's no bowel obstruction. So you can see contrast in the stomach, the small intestine, and the colon. So that's always it's a good sign. Yes, it needs a very large operation. Frequently, you can see here that's an old scar. It's going to be heavily implanted by tumor, so we have to remove that. And here's a pelvis that is impossible to make what's what. But with a little patience and dedication, here's the culprit. Tiny little appendiceal neoplasm that requires an en bloc resection of the spleen, the tail of the pancreas, the colon, the greater omentum, and all the way down to above the peritoneal reflection. And then you take that's the pelvis that I showed you before. So now everything is clean, and the only way to do this is with a peritonectomy procedure. Otherwise, it will be an impossible approach. Then we put catheters to give heated chemotherapy. So it's the 1-2 punch: surgery to take care of all the bulky disease, and then heated chemotherapy to target small microscopic residual disease. So any cells that are floating around would be addressed by the heated chemotherapy. And we can reproduce, here's the perfusion. We know that temperatures between 40 and 44 degrees they kill cancer cells. So here's a little over 42 constantly. This became we're still on the second era. This became so well known to most people that I operated on a patient from Berlin, Germany, not Berlin, Maryland. And these are her grandchildren, and you cannot read that very well, so I will have a close-up. And it says, get that pseudomyxoma out of my Oma. So my Oma is my grandmother in German. No pressure. Imagine that. They show up to the hospital wearing those T-shirts and said, I hope you do a great surgery tomorrow, okay? So everybody knew that that's the treatment of pseudomyxoma. You have to get it out. We talk about selection criteria, and at that time, I think the selection criteria or criterion was appendix cancer. The treatment was cytoreduction and HIPEC, and the outcome was going to be influenced by the burden of disease, so how bad, how much tumor is there, by whether it's a low or high-grade histology, whether you have positive lymph nodes, and a lot more by the experience of the cytoreductive team. During this time, there was some interest, but most of the answer for anyone that had been diagnosed with a massive appendiceal tumor was follow the pathway and go see Dr. Sugarbaker, and then, that was good, but, at that time it was him, and we needed to have more centers. So 14 years ago, this was pretty common, 12-hour surgery, receive some blood transfusions, a pretty high ostomy rate, complications not too bad, and look at that, mortality from the big operation, no different than any major surgical oncology procedure. The second era was characterized by the team of one, and that team was mostly the surgeon. We only had CT scans. Cytoreduction and HIPEC was the only answer at that time. And if you had a big tumor, well, you needed a bigger surgery. But then we started noticing not all mucinous appendiceal neoplasms are pseudomyxoma peritonei. And I used to say at that time, but nobody listened. I said, we need to change these to perhaps multiple pathologies. That's what PMP stands for. And I still think that that's true today. But we can discuss that later. So what happens, as things move forward, there's always a challenge. And Dr. John Marshall from Georgetown said it best, the challenge is to reconcile the varied agendas of the stakeholders to validate the standard of care. And those stakeholders include the FDA, they just want to be keeping things safe and with efficacy. The insurance companies, they want to control costs. The National Cancer Institute wants to cure cancer. The industry, market more patients. The community oncologists, they want to be efficient and keep those chairs occupied. The academic oncologists, they say, no, you need to be on a clinical trial. But the patients, they want cure, maximizing the benefit while minimizing the morbidity, which is a very important thing. And then what about research? Dr. Sebastian Rufián is the chair of surgical oncology in a hospital in Spain, and he said, just beware, there are two types of research. Those that benefit the researcher and those that benefit, patients. So even that you have to keep in mind. I had the opportunity to give a talk in Greece, and somebody presented this slide. Hippocrates said, life is short, art is long, experience is misleading, and decisions are difficult. And as some of you know, I'm not very innovative. I take whatever I see and then I give it a little twist. So now I present to you Hippocrates 2.0. I'm not comparing myself to Hippocrates, but I think that life and careers are indeed very short. We dedicate our lives to do this kind of job, but there's only so much you can do as one person. Art and randomized clinical trials are long. It takes a long time to do a randomized trial. Experience is misleading. I think it continues to be, especially when you say, in my experience, I've been doing it this way for 20 years and therefore it works. Decisions continue to be difficult, but why there is cooperation, which is what Dr. Baum already mentioned. I think cooperation is awesome. It's a powerful and great tool to achieve clinical relevance, not just a statistically significant p-value, Clinical relevance, that's what we're here for. So we have done some efforts. We created the American Society of Peritoneal Surface Malignancies. We have about 235 members from 25 countries. And, okay, I think they ended up loading a different presentation, but okay. I'm missing a couple of pictures, but that's okay. So I'll have to say it, that second era, I had a picture of myself with Dr. Sugarbaker when I was training. So I'll have to show it during the break. And then we moved to the third era, which is from 2010 to the present time. And then that third era, I had a second picture, which includes last February in Phoenix, my daughter had a presentation at the regional cancer therapy meetings, and it's a picture of her with Dr. Sugarbaker. So it was a nice thought, but okay, let's keep moving. So what we want to do is, we need a revolution, an evolution and not necessarily a revolution. So this is, we know that history repeats itself. We know that the challenge is to determine the right sequence of currently available therapies. We cannot longer use the cookie cutter approach of saying, okay, this is what we're going to do, and you need cytoreduction and HIPEC, and this works for everybody. And if you do that, more than likely the answer is going to be yes. And there's going to be some patients that are going to be overtreated, and there's some patients that, they're undertreated because that's not what they needed, And we're learning more about the disease process, and that's what we are. But something that I'm very interested in is this precise pre-treatment stratification. So everybody saw the weather forecast for today. There was a question, is it going to be a beautiful day? Is it going to rain? Yesterday afternoon, I said, I better bring an umbrella because it was raining a little bit. So you get as much information as possible. If it's raining, you get an umbrella. If it's a tsunami, you say, maybe I shouldn't walk. So it's the same thing. If we had a way to figure out who is who in terms of that mucinous appendiceal neoplasm, then it would be a better way to stratify these patients. So I have a lot of slides, but a lot of what I'm saying is going to be presented in a more elegant way as a unique presentation from the following presenter. So I just mentioned a little bit about what I have been doing. So I believe in this peritoneal surface disease severity score, and I put together this with Susana Sanchez Garcia that was visiting me in San Agnes at that time. And basically what we try to do is analyze the primary tumor. Frequently we talk about pseudomyxoma in terms of what kind of peritoneal dissemination, but there is no one single solid tumor in which the classification of that tumor doesn't involve the primary tumor, colon cancer, stomach cancer, pancreatic cancer. It's all about the primary tumor. So as you see here, they can be from a mucinous adenoma all the way to signet ring cell carcinomas. Now, the type of peritoneal dissemination is important, and I think the extent of peritoneal dissemination is also incredibly important. And with that, when we combine all those three things together, it becomes a very complicated scheme here, but I'll just fast forward to this. We analyze different patients on these 5 different groups, and then what we saw is very interesting. We have this group of patients at the top that, look at this. They all are doing incredibly well at a long-term follow-up, and these curves separate quite nicely. So when I started looking at these patients, I said, well, yeah, of course we're very good at what we do, but it has to be something else. It cannot be just the surgeon, or at that time nobody was getting any kind of systemic therapy. What has changed also in this third era is from that patient from Mexico that I showed you to this. Now somebody goes in for an appendectomy and finds just the little ruptured pseudomyxoma, just a ball of mucin with sometimes a very limited dissemination. And Dr. Siegelman is going to show you that there's no real way to show this on any kind of imaging study. These are 1 millimeter or 2 millimeter implants. Very difficult to see. What about this? A non-ruptured mucocele. This is a time bomb. You can imagine if this ruptures, then you have a massive dissemination that will lead to the pseudomyxoma peritonei syndrome. So instead of doing that very big operation, in some patients that have minimal disease, we said, let's try to do this laparoscopically. Every tumor is being treated laparoscopically. And I want you to focus that this paper was published in Annals of Surgery, a very prestigious journal in which we reported, look at this, 14 patients. And I find it very hard that you can publish in Annals of Surgery with the results of only 14 patients. But this was the laparoscopic approach to pseudomyxoma peritonea. And even we limited to patients that had a PCI of 10, so limited disease. And even the reviewer said, well, this data looks so good, why didn't you include patients with bigger PCI? So you can never get those reviewers pleased, but nevertheless, it worked extremely well. It has continued to evolve throughout the world, and just 2 years ago, the group from Spain published this. They're using laparoscopy in peritoneal carcinomatosis. So it made it to the news. Now, what about, I know that I think Bill will talk about clinical trials, and I just want to show you a little bit of a common sense approach to some of those barriers that we have. We have problems with designing a trial. As he mentioned, what is the ideal trial? Most of the times we have to move from the ideal trial to some practical trial that you can actually do because there are too many obstacles. So we have problems with patient accrual, institution participation, the length of the study, the relevance of the study. If it takes too long, by the time you're done your study, it's not relevant anymore. And then the risk of waiting to obtain that data. And meanwhile, our responsibility is the same, to deliver the best care possible. So in a very simple way, I'm going to take you through a trial design. So this is the question. Which cars are faster, American cars or German cars? So the trial, we're going to compare a Corvette against a Porsche. And then the methods, you're going to standardize everything that you could possibly standardize. So the same race course, the Nordschleife in Germany, the same pilot, the same day, the same weather conditions, same car weight, even the same color, the same tires, high-performance tires, and same 10 laps, and then get the actual timing. So everything you could possibly control for your trial. And these are the results. The Corvette, 7.45 minutes, and the Porsche, 65 minutes, with a p-value very significant. So no doubt about it, American cars are faster than German cars. Except, this is where genomic profile analysis comes to. There's something that we're not really seeing, and that sometimes becomes very obvious. Here it is. The Corvette, built in 2010 with 647 horsepower, and the Porsche Junior, is built in 1961 with an 18 horsepower. So this is where we are right now, I wish this could be that simple, but I'm telling you, this is what's happening. These, are two pseudomyxoma patients, and even though we said everything that we measure of them appears to be the same, in reality, there is some molecular signature that is able to separate them just like this, so obvious, but hopefully we'll have the answer later on today. We start looking at this, and like I said, I'm doing okay on time. We start looking at this of genomic profile analysis, and we evaluated a few patients and presented this actually 2 years ago. And we saw patients with DPAM. They had a GNAS, KRAS mutations, and you can see that most of the patients with DPAM, actually all of them, had a GNAS, KRAS mutation. I'm just going to fast forward because, like I said. But the importance of this is that this genomic profile analysis allows to see some therapeutic options for these patients. So 86% of the patients were eligible to receive a drug called trametinib, which was approved for melanoma. So now this is the future, We're going to say like, no, you don't have appendix, prostate, ovarian, or breast cancer. You have a cancer that has this particular mutation that we're going to be able to target. And as a matter of fact, when I was here in Philadelphia, we treated 2 patients with trametinib with a pretty decent response. And then, of course, there's going to be some patients that, have one mutation that there was no drug available. The conclusion of this particular study, not of my presentation, was that the genomic profile analysis is going to aid on revealing the pseudomyxoma. This is why Dr. Sugarbaker says, you have a pseudomyxoma that is behaving more like colon cancer, but that under the microscope, it looks exactly like, just mucin. And I think that's the difference between the Corvette and the Porsche, that we just cannot see it. And I think that the presence of a SMAD4 mutation, a mutation that is present in pancreatic cancer, those patients really behave with a very bad clinical presentation. This is where I was going to show the picture of Dr. Sugarbaker with my daughter, but this was presented, like I said, just our latest meeting of the regional cancer therapies by my daughter. And so the background is the detection of what I call here the NIMANs, the non-invasive mucinous appendiceal neoplasms, is definitely on the rise. I think that we're seeing more and more of these patients. Many years ago, a few decades ago, if you had an appendectomy, they didn't even send it to the pathologist. So I think that's part of the problem. We know that it takes a long time, if you have a ruptured mucinous appendiceal neoplasm, to develop a pseudomyxoma peritonei syndrome. But the bottom line is that nowadays, how to cancel these patients represents an oncological dilemma. And for this presentation, this NIMAN included what we call the low grade and the high grades and the mucoceles. And again, we did the peritoneal surface disease severity score, which is a combination of the primary tumor, the type of peritoneal dissemination, and the amount of peritoneal dissemination. So we had 424 patients with mucinous appendiceal neoplasm. We were able to calculate the peritoneal surface disease severity score in 127 of those. 65% were female, and the median age was 57. And I'll bring to your attention, from 11, I had an 11, this is at Frederick now, 11-year-old had an appendectomy, and he came back with a ruptured mucinous appendiceal neoplasm. And I talked to Andrea Hayes Jordan, and she said she's a pediatric surgical oncologist. She said she's never seen that. This is how they were divided, and the treatment, you can see 90 patients of the 127 had cytoreduction and HIPEC, 26% of them laparoscopically. So not everybody got cytoreduction and HIPEC, 26% got it laparoscopically, and the rest got it open. And these are the results. So this, if nothing else, I think this is the punchline. Out of 29 patients that had what we call no evidence of peritoneal dissemination, and how do we know that they had no peritoneal dissemination? We did a peritoneal metastasis protocol MRI, and I know that Dr. Siegelman is going to show that better. I also had a slide of a pocket knife with one blade is CT scan, and then the Swiss Army knife is the MRI, with all the other blades, and I'm sure he'll talk about why is that. But no peritoneal dissemination by MRI, 29 patients, even 12 patients that had not ruptured tumor and 17 that had it ruptured. You can see here at a 42-month follow-up, all of them alive and all of them with no evidence of disease by MRI. That's of course the disclaimer. We didn't take them back to the OR to do a laparoscopy, but a pretty significant follow-up with no evidence of disease. And the beauty of the MRI is that there is no radiation. We do MRIs on pregnant women, so that's very important. As the peritoneal dissemination increased, so 39 patients with a PCI of less than 10, you can see here, appendectomy only in 8 of them. The vast majority of the laparoscopic cytoreductions were in this group, but even some patients that didn't want to have a laparoscopy. And I have 2 patients in which I proposed to do this laparoscopically, and they said no, because at that time there were still comments of, no, you cannot see well, and it's not appropriate. I think the most important thing is to determine the severity of the original tumor, and that determines how you're going to treat that particular patient. And as you can see here, also quite a bit of a follow-up, and 100% alive, but now we did start seeing 5% recurrence rate. As the peritoneal dissemination increases, the rate of recurrence increases. But of those patients, one had an open cytoreduction, and the other one was just a follow-up. And the ones that had a recurrence was one in the appendectomy and one in the laparoscopic cytoreduction, and came back 8 months later with one little dot behind the spleen that now 3 years later hasn't changed, but is called a recurrence. Once we move to the burden of disease starts getting significant, from PCI at 11 to 20, we have 20 patients, and now, yes, you can see the recurrence rate, 25%, but again, a very good long-term outcome. And once you get to the patients like the picture that I show, if you really, really look into it with an MRI, then the recurrence rate is quite significant. And the treatment for those patients, it varies tremendously. Some of them didn't have any other operations. Some of them had a second cytoreduction. There's a patient, everybody I think knows the name of David Bartlett. So Dr. Bartlett operated on one of these patients in the year 2000 for the garden variety pseudomyxoma at the National Cancer Institute. They did a HIPEC, very intense at that time, and I reoperated on that patient 14 years later, in 2014. And this tumor had evolved into just a massive amount of lymph node positive signet ring cell carcinoma. Hard to believe, but 14 years later. So things do happen. You have to follow them for a long term, and therefore MRI is a way to follow them. So in my kind of common sense approach, we'll see that an analysis of this data shows that Niemann, so these non-invasive mucinous appendiceal neoplasms, represent a spectrum of tumors with a wide range of histological features. Our goal is to distinguish that Corvette from the Porsche Junior, and with biological aggressiveness that also can change tremendously. So not all the patients with Niemann will need cytoreduction and HIPEC. And I think that the most important prognostic factor, other than the biological and molecular marking, is going to be the extent of peritoneal dissemination. With that, I will conclude with, like I said, a common sense approach. Patient gets an appendectomy, it has to have a very comprehensive pathological analysis, which if I had the magic wand, that would include a genomic profile analysis that's going to tell me, is it going to rain or is it going to be a tsunami, and then I can prepare accordingly. I think the patients need to have a peritoneal metastasis protocol MRI because it's a much more dynamic test than just a black and white CT scan. And then based on that, we're going to establish the severity of the disease, of the peritoneal disease. If the patients have no evidence of peritoneal dissemination on an MRI, then those patients are done just with the appendectomy. Even if you have a positive margin, there's data that shows that when, just like in breast, when you take them back for a re-excision, you never find anything. If they have E1, so a PCI 10 or less, I think those patients should have a laparoscopic cytoreduction and HIPEC. The length of a stay for these patients is 4 days. The length of the operation is about 3.5 hours. It includes 90 minutes of HIPEC. And on the other hand, if the PCI is more than 10, I think that you need to have an open cytoreduction and HIPEC. And with that, I want to thank you for your attention. I apologize I went over a few minutes. Thank you.